quite a lot of issues to discuss today. No one can say that COVID is a quiet matter just right now. It's big politics. It's unfortunately still big sickness. And it's also big in the economic and social impact. Every one of us is somehow tangled up with COVID issues in our lives. And so today I want to take stock, as I'm doing in the current third series, bringing you up to date with what I'm hearing and seeing from around the world, connecting all the time with my colleagues, Catherine in particular, who's giving me my primary steerage, but also John, Twee, and other members of the team who I hope will be on. But because we have now been coming together in a very regular way for really quite a lot of months, I want to celebrate the fact that we are a group and that we have a really strong bond with each other. And so I am really keen that we have a lively discussion. And I'm going to say to you, Twee, if I go on too long, just stop me, because I really would like to have half an hour for family discussion amongst ourselves. So I want to greet Pete Morey, who's with us very kindly doing the illustrations. I had a lovely the other day from a person who's been with us on several of these sessions saying, your live illustrations are so good. So it enables me to say to Pete, and through Pete, the whole team, thank you for being with us and giving us the illustrations. But and when you've got somebody illustrating, then I think it's useful, if you're going to do a briefing, to set out the structure of what you're going to say in advance, so that helps with the structure of the diagram that's coming up. So here's what I'm going to do. I want to talk briefly about the pattern of the pandemic currently. And I want to do that each week because it is changing. And I think everybody who's looking at the numbers is thinking, well, what's going on here? So I'm going to talk about that. And I'm going to talk about it with a truly global perspective. And I have the advantage that because of my work on food systems, I'm in contact with teams in different countries all around the world. And I get quite interesting extra information that I can then lay against what I'm getting from the WHO surveillance. And I'm going to present you with some nuggets from my round the world Zoom tours. Then I want to talk about some of the issues related to access to technologies that are able to make a difference. And I want to start by talking about access to treatment if you've got COVID, and you'll hear why when we get to that point. I want to talk about tests, and then I want to talk about vaccines. And of course, on vaccines, there's such a lot of stuff in the media. So I'll just try to summarize with some broad headings what I think the issues are. I will go to the Security Council that took place earlier this week. I will go to the G7, which is taking place around now. I don't know whether it's finished or not, but I've been quite well briefed on what's going on there, but we will need to watch the outcomes. And then I will come to the question of where things are going in the future. And I am going to focus not just on COVID, I'm going to focus also on Ebola. And I'm going to just make the point that COVID isn't the only threatening infectious disease that we've got in the world today. Just because I've got almost a deja vu about the Ebola situation after my involvement in 2014, I want to cover that as well. And then I want to look ahead longer term, just so that we can all be on the same place. Okay, so that's the structure, and Twee and other colleagues, just agitate, move your hands. I'm trying to keep looking at the camera, but I will tell if there are things where you want me to shift. And could you please, if you're thinking that you'd like to make a comment or two, especially if you would like to come in and make a comment live, please put your name in the chat. Catherine, I'm working in a pretty massive degree of isolation at the moment, so I'm on my own. and I'm connecting with Catherine by WhatsApp. So very, very useful. Catherine, I have to check which WhatsApp group you're connecting on, but I think it's the
we'll use the OOB one today, David.
Series 3 OOB. I've got that. Good. So as I look at the overall numbers of people with COVID who are being reported to WHO, they're going down all over the world. And I mean, the overall WHO epidemiology figure is beginning to show a nice downward curve. I've learned when working with other epidemics that the aggregate curve, it's a great thing to tell you what's going on total, but it actually disguises a lot of micro details. And that's really what I've got to get to today. And it's building on what I said last week. Yes, there's a decline. And most of that decline is to do with the application of non-pharmaceutical measures, the reduction in the amount that people are in contact with each other, the use of face masks, the better isolation, together with good hygiene. It may also be that in some parts of the world, there's quite a lot of people who've had COVID, perhaps asymptomatically, and that's also reducing the opportunities for infection. I think it's too early to say that vaccination is contributing to reduced incidence, but it may be that in some settings, vaccination is leading to reduced deaths. And that's certainly what the case that's being made for the analysis in the UK. Now, at the same time as the numbers are going down, there are some really aggressive hotspots where there's a lot of disease, a lot of illness, and quite a lot of death. I was just going through the COVID case fatality rates, i.e. the death rates of people diagnosed with COVID in a number of sub-Saharan African countries, particularly in Zimbabwe and in Lesotho and in South Africa and in Botswana and Malawi. They're variable, but in some cases they're at 8%, between 5 and 8%, pretty much in the region. I've been talking to people who are involved in providing hospital care in Southern Africa. They are in a bad state. Shortage of staff, partly because staff dying, partly because of staff having been contacts and having to not go to work, partly because staff don't want to work because of inability to get all the protective equipment they want. And the fact is that this has been particularly nasty for health workers. I can't give you numbers, but it's not good. I mentioned last week the high-profile illness and death of government ministers and of civil servants. And I mentioned that we've had to do a lot of evacuations for the UN. So these hotspot, what I'm calling aggressive hotspots, difficult surges, are occurring. And most of the information I'm getting is from Africa, but I'm also hearing in Latin America, particularly at the border between Peru, Colombia, and Brazil, there's also a particularly difficult situation. The situation in Malaysia, which was bad, seems to be getting better, but parts of Indonesia have still got bad COVID. India is okay. Nepal seems to be okay. That's what we're told by people on the ground. Sri Lanka getting a bit better. So that South Asia area, generally not so bad. And then in Europe, numbers are starting to go up again after dropping down following the latest lockdowns, going up again in some Eastern European countries, particularly Poland. And honestly, they're very likely to go up again, even in the countries that have showed a really rapid decline recently. I mentioned that in the Moselle area of France, there's big anxieties about new variants and the possibility that that's going to really change the dimensions of the outbreak in France. All the time, we're getting information that this is increasingly a disease of poor people, disadvantaged people, deprived people, people who are less easily able to work and live in ways that follow the precautions that we all talk about. And that's not surprising, is it? And some really quite detailed analyses of that. The variants continue to emerge. And in fact, they're emerging quite rapidly. There is one particular set of mutations around the spike protein that seems to be found in quite a lot of variants that make the virus more transmissible and nastier. And at the same time, there are concerns about whether or not vaccines will be able to produce an immune response that can neutralize these new variants. Now, most of the way in which the vaccine capacity is being assessed is by looking in laboratory studies at the ability of blood from people who've been vaccinated to kill the virus because of the antibodies inside the vaccine. And we're finding that both the Pfizer-BioNTech vaccine and the AstraZeneca Oxford vaccine seems to be unable to produce antibodies that will defend against some of the newest variants, particularly the one that's being characterized in South Africa. But I want to stress that just because the antibodies or the blood from a person who's been immunized don't neutralize the virus, it doesn't mean that the human body can't do it, because inside a body, there are two kinds of immunity that are provoked by a vaccine. There's the antibodies, and that's called humoral immunity. And there's the cells, and that's called cell-mediated immunity. And it's the cells that get really turned on and go and surround virus particles and the inflammation caused by a virus. And sometimes they do it rather dramatically. And that leads to a thing called a cytokine storm, which in turn can be quite dangerous for the person. You kind of almost overreact to the virus. Now, when these people who've been vaccinated, when their blood is being tested against the variants, that's a test of humoral immunity, but it's not a test of the cell-mediated immunity. So just because the antibodies that are produced in people as a result of immunization with the AstraZeneca Oxford vaccine, just because the antibodies don't seem to work so well, that doesn't mean that the person will not be able to respond to the virus. And so I'm encouraging people to continue using these primary vaccines and to get people immunized with these vaccines and not to give up on them. There's just been a bit of a walk away from AstraZeneca Oxford vaccine, almost a discussion of it being the second best vaccine compared with some of the other vaccines, particularly Pfizer-BioNTech. And I'm saying, don't think that. There's just no evidence. Yes, the antibodies produced in response to some of these vaccines may not be so effective at killing the virus. There's a lot more that goes on in a human body when you're immunized beyond the antibodies. So keep vaccinating, I say. Use the vaccines we've got. Of course, the scientists have got to get on working with the variants and have got to make tweaks to their vaccines. That's the way it should be. But basically, I'm saying keep going. And that really is important to me. I said that I wanted to particularly focus on treatment. You know, if we've got a situation where when you've got COVID and you go to hospital, you're not able to get the treatment you need, you can't get oxygen, you can't get what they call patient monitoring for your blood oxygen content, you haven't got the staff who can help you to breathe when your lungs really harden up, that's a bad thing. We shouldn't be having death rates of up at 8%. That was what happened in Wuhan at the very beginning. And what's happened, particularly in UK and other parts of the world, is they've got the fatality rate down to less than 1%. So these figures that are coming through from sub-Saharan Africa are given to me today by the WHO team in sub-Saharan Africa are worrying. And when I combine that with messages I'm getting, even from countries that are just saying to Peter, just blank around this bit. There are some countries that don't recognize they've got COVID, particularly Tanzania. But I'm hearing from people in Tanzania that it's a really serious issue. They just don't use the word COVID when they talk about it. And the hospitals are full. And when people go to hospital, there's a pretty high likelihood that they will not come out alive, especially if they go when they're quite sick. So I am really raising in my mind the priority of supporting clinical care in hospitals, in places that do not have good clinical care capacity, because I'm really alarmed about these high death rates. And that means fundamentally oxygen. My colleague Mike Ryan at WHO says the best thing that you can offer when you have got people coming in with a disease like COVID, where their capacity to inflate their lungs is greatly limited because of because of water getting in the walls of those little membranes where the air exchange takes place. And so the lungs become really rigid, and breathing is just super hard work. You have to lay people on their tummies and on their chests and try to help them to breathe that way. But the most important thing to offer them is oxygen, not necessarily with a ventilator, but just slightly positive pressure of oxygen. And so for me, enabling hospitals in poorer places to have access to oxygen through oxygen concentrators, to have access to these tiny little things called pulse oximeters you put on your finger that tell you how much oxygen there is in your blood. They're lifesavers. And they only cost about 40 euros each. But they're terribly easy to put in your pocket. So they don't sort of stick around. But getting access to those monitoring devices, and then getting access to the basic therapies that are so important, particularly dexamethasone, which is a real lifesaver when people have been in hospital for a bit. That's something I want to prioritize. So I've put it higher up in my priority list, is just remembering that there are a lot of people dying whose lives could be saved. My number 2 in my priority list is these rapid tests. You know, in many, many places, getting a quick response when you're doing a PCR test is really, really difficult. Even in the UK, there's been quite long delays on PCRs. And the Prime Minister of the UK has said, well, we're going to move to rapid testing. And rapid testing is done using a kind of test called an antigen test, which is picking up bits of the virus. The only difficulty is that they're not very good at picking up bits of the virus when you don't have much virus in your specimen. And they're also rather unsatisfactory if you're using the test to screen, to pick up the 1 in 100 people who might have COVID, for example, at the boarding gate of an airplane. So the rapid tests are there and they're coming on stream, but they're immensely variable, and not everybody thinks they're great. Yet they are for sale in pharmacies all over the world. They're being used in lots of different settings in order to say whether people have got COVID or not got COVID. And so I'm starting a bit of a campaign to say, use the rapid tests that have been given the emergency use license by the WHO. And Catherine and I are trying to check out exactly which tests they are. I have to hunt through the website to find this stuff. I can't give you their names now, but Catherine may well have that information. But rapid tests really matter. So I'm also encouraging everybody who's developing new rapid tests, particularly the people who've got rapid tests that look like they're going to be super reliable. I'm saying, oh gosh, we're waiting, because we're going to need them in the billions. Because particularly if a rapid test can be done somewhere quickly and without need for a lot of preparation of the sample, and if you can get a result quickly, and perhaps you might need a skilled person to interpret the result, in fact, I'd encourage that, but that could be incredibly useful. Just imagine you could get the same reliability that we have at the moment with a PCR, which takes several days to actually give you the result in many places. Imagine having that in 15 or 20 minutes. Well, I think it's not far away. And so I'm really, really keenly advocating. And I keep saying to people, why all this fuss about vaccines when actually the things that would make the biggest difference are rapid tests? And then, particularly in poor countries, is access to just the basics of care that will make a difference. Catherine and I are working in a public-private partnership that is trying to really improve access to low-cost intensive healthcare. It's tricky because it's not just about supplying kits, supplying ventilators and so on. It's actually helping to get the systems working better. And that's where teaming up with people in hospitals from poorer countries, particularly networks of hospitals that are trying to find ways to get this right, is so important. I think we're going to get more of these surges, more of these hotspots emerging. I just can't see it not happening for the foreseeable future. So rapid tests, access to treatment, and making certain that we are just keeping our eyes open and not letting our guards down is so important. Just a moment or two on vaccines. First thing to say is that the UN Security Council had an event to talk about vaccines, and the language was strong. No, it is not being, I'm going to say, leaders of middle income and poor countries are not excusing the leaders of advanced countries for the vaccine grab that is underway at the moment. And the statistics are appalling. Mr. Guterres mentioned it in his speech on Wednesday that, yes, there's a sort of millions of doses of vaccine being given, but the vast majority are in rich countries. And the way it's being presented as a policy choice is we've got to look after our people first, and then we'll give our spares to poor countries as a gesture of goodwill. That's no good. Absolutely no good. I'm rather pleased that there's just the beginning of the emergence of some leaders of rich countries who are saying, actually, we think it's necessary to share our vaccines because this is a global issue. And the only leader who's really said it convincingly so far, is President Macron. But in his interview with the Financial Times that I think was yesterday, I was really impressed by his approach. So let me just give you the statistics and facts as I know it. Number one, this is a global pandemic. The virus is everywhere. The virus is able to mutate everywhere. It needs a global response. From a public health perspective, it makes absolute sense to say, currently we have a limited availability of vaccines and even less vaccines that have been through the WHO licensing process. It is essential that these are distributed on the basis of need rather than on the basis of greed. And the need is particularly for health workers and high-risk population groups all over the world. It doesn't matter where they are. So that's the public health argument. It's an absolute no-brainer argument. But then there's the economic argument, the analysis by the International Chamber of Commerce, analysis by the World Bank, other analyses by the IMF, just saying, if there is not equitable distribution of the vaccines, if there is not at least some recognition that this is a global problem, the economic impact on international travel and trade will be substantial. And then the third argument is the straightforward political argument that the West will not be forgiven for decades if this current practice goes on much longer. And it will make, as with many other issues we have to deal with, it would just make the negotiation of how we deal with global challenges like climate change and so on, just all the more difficult if we have yet another example of rich countries saying, you know, we will abide by our rules and we will not follow global rules. I'm not going to talk about vaccine equity because nobody understands what equity means beyond groups like ours. I am going to talk about access to vaccines, or I might even modify it, talk about access to vaccinations, because it's not just the vaccine sitting in a cold store in the capital city airport. It's actually getting vaccines into people's arms and following them afterwards, because it's no good just doing it and then saying bye-bye. So I want to really get that message right. All of you, if you feel like it, there is the thing called the Vaccine Equity Declaration that's WHO and others have been leading on. It's on my social media. We tweeted it, I think, yesterday tweet. And there is also a campaign being done by Christian Aid. There's a campaign by One. And I think it is important to let these campaigns really take off. They are vital. I wanted to say that there are some challenges because of the lack of vaccines in poor countries. There are some challenges because poor countries are accessing vaccines that have not received the emergency use licensing. Instead, what's happening is that the national governments are using their sovereign authority to authorize the experimental use of certain vaccines without requiring them to have had the WHO approval. All I'm saying about that is it's a little bit dangerous. And I am urging all countries to pay attention to the WHO emergency use licensing process. It's not there just for fun, it's there for a reason, which is that there are vaccines are biological substances. The manufacturing process is complicated. It's quite easy to get contaminants in the manufacturing process. It is known from previous occasions that very rarely batches of vaccines can be contaminated with funny things, prions particularly. And so the whole process of the emergency use licensing is designed to protect the public from these very rare things that go wrong. And I don't actually want to encourage vaccines that haven't received emergency use licensing from being used by countries just because they've got to deal with massive public pressure, because people are just getting so very frustrated because they see how rich nations are just hoovering up the vaccine and keeping lots of extra in the back pocket. So we'll continue working on that. Some of you have said, is the COVAX scheme not surely going to deal with all these problems? Yes, COVAX is brilliant. I told you last time, it's got a subsidized portion for 96 countries. It's got an unsubsidized portion for any other country. It's basically a bulk purchase scheme that enables everybody to access vaccines quickly. But COVAX will only distribute vaccines that have been through the WHO emergency use licensing process. And if those who produce vaccines are not getting their vaccines properly through that process and are just simply wanting to do bilateral deals, then COVAX can't use them. And of course, we'll end up with people saying, well, I get a little bit from COVAX, I've got a little bit from that country, I've got a little bit from this businessman who's offered me some vaccine, and you get a sort of vaccine mosaic. And one thing I'm saying is vaccine certificates are essential, because you need to know not only what vaccine people have received, but what batch of vaccine people have received. And that needs to be somehow very, very close to them, because if we do get side effects with certain variants breaking through with particular vaccines and we get problems, then it's really important to know which vaccine and batch people have been vaccinated with, so that one knows what to do about it. So to deal with the vaccine mosaic and to deal with the mosaic of variants, I am really keen that there is a strong global scheme for surveillance that keeps track of what vaccines are being used, as well as what variants are emerging where, in order to try to make sure that this doesn't become a total mess. It's not impossible. This is all doable, but it requires just a little bit of farsightedness by leaders who've currently got themselves stuck in a little bit short-sighted anxiety about how they fulfill their pledges to vaccinate their populations when they can't get the vaccines they want. A bit messy. Just lastly then, I wanted just to stress that the arrival of a few cases of people with Ebola in Guinea, and unfortunately some of them have died, and then suspect Ebola in Liberia over the last 2 or 3 days, is not good news. Because the people that you pick up are the tip of the iceberg. And what happens usually is that it's pretty quiet. You just get a few people with disease, and then suddenly you get a surge. And that's pretty similar to what we're seeing more and more with COVID around the world. You get sort of low level, and suddenly it picks up. We don't quite know what leads to these explosive outbreaks. We've had them. I mean, remember, Wuhan was an explosive outbreak. I just talked to the leader of the team who was in Wuhan looking at the said, well, we know that the virus was circulating in Wuhan at least 6 weeks before that whoosh that they had. Well, we've had the big explosive outbreaks in northern Italy, in 3 parts of Spain, in various parts of France, and parts of the UK. It's become a bit more consolidated recently, but this capacity of this virus to cause explosive outbreaks after being quiet for a bit is definitely there. And so both Ebola and I think COVID are likely to be, we don't watch it, emerging new threats. So that's all on my mind. And looking ahead, I'm not pessimistic. I think that although I get frustrated about the narrative and frustrated about what I read every day in the media, in the US and in Europe, and indeed I follow South African media and I follow Indian media, I'm still confident that the kind of narrative that I work with, and the same narrative, of course, that the technical teams in WHO work with, but more and more, I sense that this alternative narrative, virus is going away, that we're going to have to watch out for the variants. We're going to have to be very careful about the vaccine mosaic. We need to get COVAX to work. And most importantly, we need to have a global program for ensuring a proper rollout of vaccines so that they go to those who need them first. I'm hopeful that this narrative will become more mainstream. And although people say that Einstein said that the definition of a fool is somebody who goes on doing the same thing again and again and again and expecting a different result over time, I actually think that consistency of messaging and indeed of explaining is important. And so we're following the messaging that I've developed with you all in our interactions with businesses who are super receptive to what we've got to say, into our interactions with government, where we at least manage to get the message through to the technical people, not so much the political people, and into our interactions with professional groups who I think feel that what we're saying has a lot of sense to it. So that's my quick briefing. I'd like to go back to Twee and for her to now do the part that I know she's been preparing for. And also, if you'd like, Twee, could you share what's on the LinkedIn?
Absolutely. So just to say thank you to all of you who have been contributing really up-to-date news on our LinkedIn community chat. Please keep that going. It's very useful for us as a team to keep on top of what's out there and what you're picking up. So as an intermission, while we collect all of your comments and questions for David, I'm going to launch a little poll for us, as usual. So question 1. Why is the main reason, I didn't write this correctly, what is the reason some pathogens can't be eliminated? Option 1, some exist in humans and other exist in, that should say, other reservoirs. 2, our test and trace systems are not advanced enough. Or 3, the half-life of some cells is too short to allow sufficient research to be conducted. So that is, so the question again, sorry, is what is the main reason some pathogens just can't be eliminated? Question 2, what is the oldest regional public health agency? 1, Africa CDC. So those of you who are on the quiz a few weeks ago may know whether that is or isn't the answer. 2, the Caribbean Public Health Agency. Or 3, the Pan American Health Organization, or PAHO. And question 3, this is the fun one that I like to do. Which of the following have you picked up in the past year? Multiple choice, you can select as many as you like, and the answers are anonymous. So while you're answering that, I will spotlight the beautiful illustration being done by Pete Morey of Live Illustration UK. Peter, would you like to share what you've drawn a little bit with us?
Hello, yes, okay. I find this quite difficult to read through as a summary, but hopefully you can see, and maybe I can help guide your eye around the image. So we've got the summary of the structure of what David was talking about on the left, talking about the pattern of the pandemic, access and types of access to different things. And then the third is the future, involving COVID and Ebola. Parts of the image that I enjoyed drawing with I think, is it Nazim, the musician in the bottom left? I wanted to put in a line. Maybe you can help me with the line summarizing his lyrics, his key message there, that just go across the top next to his face. I've got representation of hospitals and areas of hotspots, it's sort of to the middle and to the right. And down at the bottom, if you follow the sort of speech bubble tracks that are sort of linked together, you can see a sort of argument about new strains being real, and vaccine grabs are a thing. And then potentially a notion of solutions towards the bottom, keeping track of types of vaccine, certification, and having a global response.
Fantastic.
I hope I did it justice there.
Thanks, Peter. And that grabbing hand is it's very well, a good illustration there of what we meant. So thanks, Pete. I'm gonna end the poll now and share with you the results. So for question 1, the answer is indeed the one that you all got, most of you got correct, is some exist in humans and other reservoirs, including bats, mosquitoes, monkeys. And humans have only ever eradicated one disease, which is smallpox. The answer to question 2, most of you got this right, it is the Pan American Health Organization. And after World War II, there was an agreement that it would be part of the World Health Organization, but PAHO remains its own legal personality. And then question 3, it looks like many of you have taken up these things. About half of you have taken up all of the options that I put there. I wanted to point out the answer 4, brightening the home with flowers, was an interesting thing I learned last week, is that the flower industry in Kenya, which was like many industries suffering quite a lot last year after COVID, is booming, and in some places greater than it was before. And some of this can be referred to or attributed to people saying that flowers in their home is a nice way to brighten their home despite being in lockdown. Thank you, that's all from me. Back to you, David.
Gosh, Tree, thank you very much indeed. Everybody, there are lots of suggestions coming in for comments and so on. And I kind of, first of all, Lewis Thomas, if I can find you, I've got to get back on the gallery view. Lewis Thomas, I think you're in a hospital somewhere. And I always love it when you tell us what you're seeing. But are you on, Lewis?
David, I've just had a note from Lewis saying he's had to deal with an immediate operational issue and has therefore just dropped off this minute. So
okay,
sorry, we didn't get
thanks a lot. Okay. Leah Lucas, are you here?
I am.
Tell us what you were picking up from Mike Ryan, and where are you calling from, Leah?
I'm calling in from the US. So hello from.
Hi.
Good morning in our neck of the woods.
Yeah.
So I referred to Dr. Ryan with the WHO, his recent article referring to Ireland and discussing how, Ireland needs to face now this sort of moral dilemma of vaccinating young individuals who are healthy. So I feel quite similar to this demographic. I'm young, I'm healthy, I'm from a developed country. And what type of moral implications do you think that individuals should grapple with as, being an individual that doesn't necessarily need to be prioritized for a vaccine, but perhaps being in a location where I could receive one in the near future, but feeling that really moral weight of the fact that so many individuals in the world and refugee camps and all of these areas really are the ones who need the vaccine. So maybe you could offer some guidance or some thoughts. Thank you.
So Leah, I'm going to comment on this, and I hope others will. The thing is that political leaders in many countries perceive that their primary obligation is to their citizens, and only a secondary obligation is to the world as a whole. And they also perceive that their citizens want them to actually get as much vaccine as possible for them, whether they're young or old. They perceive that that is the mandate they're getting from their people. And so what's necessary is to find a way that will let our politicians off the hook. People like yourself, in the hundreds of thousands, finding a way to say to your political leaders, look, if there's a choice, I'd rather you prioritised vaccines for exposed health workers and high-risk people in other countries rather than vaccines for youngish, fit people with very low risk in our country. And we have to find a device to let politicians off the hook. Mike himself believes that. I suspect in the interview that you might have heard part of, he might have woven that into his remark. There's no simple process in our democracies to release politicians from perceived obligations to their constituencies. This is something that we need to try to invent now. Leah, I challenge you to think through how one might move forward with such an initiative, because it would require a movement of people. It would require quite a lot of stewardship. It would earn a lot of aggression because the people on the other side can be really horrible. I found that out after I did a few interviews. But my own belief, it is to somehow, I can't find another word for it, but let the politicians off the hook. I welcome other comments on this, and that could be done either by you waving or by putting it into the chat, and we will hear about it. Let's just get Claire Rayner. Claire, are you on, please? Claire. There you are.
Sorry,
Claire is remarkable because she's done some really brilliant work on long COVID, and I'm just so pleased with what you're doing, and it's amazing how the work you've done has actually stimulated action elsewhere. And obviously, a lot of this conversation where we say young people are not at risk, of course, is ignoring that some of them do get nasty long COVID, and so you might have a view on that. But also, I thought, Claire, you might want to say a little bit about this clinical dilemma, and in poor countries, what can be done to help people not need to go to hospital? What can be done at home? Over to you.
yes, thank you. I put a little bit about that in the chat. I've been feeling really strongly about this for a long time, and I think it's been forgotten. We've forgotten to think about the simple measures that might be able to help people manage symptoms. I think both in our own more developed countries, but also in other countries. And I have a feeling, well, it's like everything. As you know, prevention is better than cure. Why aren't we thinking about stopping the illness being as bad? And I think there are some really simple things. I've had COVID myself twice now, I think. I had first episode lasted for about 9 months, and then I immediately, to my surprise, got it again. But there's two things that I noticed amongst the many, that it's a disease that when you get it makes you very sleepy in the acute stages. It stops you remembering to drink. So we need some really simple health messages about, because I think that's something about the coronavirus that's very specific. You become very drowsy and very sleepy, sometimes quite apathetic, and you need reminders to drink. And that sounds so basic, but I think we're forgetting things like that. And that almost needs another person to say, right now, wake up and drink. And the oxygen things that you've said. So those are just a couple of initial thoughts. I'm perplexed as to why there is no research going towards early treatments. There are things like antihistamines, cheap, available, which seem to help the inflammatory effects that go on. But I'm talking basic health messages like hydration and you know, vitamin D. Why aren't we getting the message out there about everybody being, you know, it helps. We need to be vitamin D replete. These are my initial thoughts. I just think we're missing out in all countries on the management of symptoms in the early stage.
Claire, are you still engaged in the work on long COVID and some of the effort to try to get it better recognised and also better prevention and management?
Very much so. I feel that we're making no headway, which sounds very negative, and I'm not a negative person. But I feel that I and my compañeros, as I call them, have been saying the same things since May and June, which is when we first started saying this. And I think we're up against a lot of the medical profession not seeing, not listening. And I know there are huge pressures for them, but we continue to be faulty. Yeah.
You continue, and keep on my back as well, because this is, it's being ignored and it's so important. Your point about the exhaustion and drinking, point about checking oxygen concentration, which, as I mentioned, is not an easy thing to do.
No.
And vitamin D and antihistamines, all really well taken. And I mean, also tracking the literature on statins and angiotensin reuptake blockers, but particularly statins, because there's a lot of people saying, well, we should use these low-cost therapies, but there are others, and I don't quite know where they're coming from, saying, no, we've got to go for more expensive treatment. So I think what Claire is saying is really important. Claire, please keep in touch. Please keep calls. Tell us where you're getting to. And by making that point, it empowers me and certainly my colleagues to follow it up.
Thank you so
Thank
much.
you.
My other little thing is, because my background is an occupational physician, and I care ridiculously passionately about people being able to work all across the world. It's absolutely important. And I've written a little leaflet, which has been endorsed by the Society of Occupational Medicine, all sorts of people here, about to try and help people to speak to employers or to get into work. So if you would like, I will forward that to you. It's one of my efforts.
Absolutely. Please send us stuff and share it. There is a bit of a debate about vitamin D, but I've got one comment on what Claire said. Many of the trials that have been done on various therapies have actually only included people who've got quite late stage illness. Claire's point is that there are things you can do early that might obviate some of the problems, might diminish some of the problems later. So I'm personally not wanting to discard the possibility that antihistamines and vitamin D could be helpful if taken early or taken prophylactically. So thank you very much indeed. Somebody has put in the text that good nutrition is also important. Absolutely. And I'm getting texts also saying, stress that being in good nourishment, having a lot of sleep, maintaining your exercise rhythm, all these things help your body to be able to be less affected by this virus. Claire, thank you. You have all our support and solidarity. I can speak for everybody on that, and so glad that you've been able to continue this work to try to get attention to long COVID. Let's just go quickly to Yusuf, please. Look, Yusuf, first of all, you're seeing this giant experiment of the rapid rollout of the Pfizer-BioNTech vaccine in Israel. You will be able to tell us a bit about what the impact of that is, and you might also have some comments on what's happening about the numbers around the world. Yusuf, you have the floor.
Thank you, David. Basically, my comment was a question to you, because I sense globally and also in Israel, there's some kind of seduction taking place about these numbers, and I'm suspicious about whether the numbers are truly reflective of the situation, both because of testing fatigue, and secondly, because of weak monitoring outside of developed areas, urban centers and other developed areas. And I say developed in quotes. So that's one issue. But something that we are seeing in Israel, we have now, I think it's something like close to 50% with at least one injection and about 25% with both. We're seeing a decline in numbers of reported infected people daily. But I think that also the number of people being tested is declining. However, there's an opposite trend that's still very worrying. The number of people in serious critical condition. Also, we're seeing a tendency of younger people acquiring serious illness, including pediatric cases, including neonatal cases. And last week, a fetus died, in which they're presuming both mother and the fetus had the virus. We're also seeing a lot of people, and there was a report today of a longitudinal study by a professor at Hebrew University of people who were sick in March and April being followed till now. And 50% of them report at least one symptom. Some of those are new symptoms, symptoms they didn't experience at the initial onset of the disease. And these are people where the virus has long cleared their system. In other words, long COVID. I think something that needs to be stressed about COVID is that it's not only mortality, it's not only morbidity, it's leading to at least short-term and medium-term and perhaps long-term disability. And that we haven't even begun contending with, which is going to be an ongoing factor that we're going to have to carry forward in our considerations. Thank you.
Yusuf's observations align 100% with mine. And I'm super grateful to you for making that point. But everybody, this slight change in the symptomatology that's happening in Israel and the increase in numbers of youngish kids coming in is important. It's the same sort of thing being reported from different parts of the US. So watch this space. Thank you, Yusuf. We've got about 9 minutes left, colleagues, and I'm super keen to invite a few people to make quick remarks. Members of the team, don't hesitate to butt in any time. It's much nicer when you do, rather than me coming to you out of the blue. I think, Kathy Matthews, you had something. Could you just quickly say it, and then we'll see what we do about it. Kathy, where are you? Looking. So difficult to find people. Are you still there? No.
Yes, I'm here. Thank you, David. Just a quick question. So again, just deep appreciation for what you're doing. This makes a world of difference to us to be connected to you. Thank you. I know it's exhausting. Just a practical question. These rapid tests, if somebody gets a negative result, and let's say there's a 90% probability with that particular test that it's accurate, do you have to wait a couple of days to really know that you don't have COVID?
I fear that a negative result from many of the rapid antigen tests is not necessarily a negative result. There is considerable insensitivity, and it's necessary to repeat the test and repeat. And just, I mean, obviously, if you've got really low virus concentration, multiple repeats won't turn it up positive. But there is some improvement in sensitivity by repetition. But basically, a negative rapid test is not a clean bill of health. And we're trying to check to see whether we can get the names of the rapid tests that are thought to be the most reliable. And we'll try and get those during the week. And if I will ask Catherine or Twee to make sure it's on the WhatsApp group. I'm sorry I can't be more help. Marianne, please, quickie from you would be great. Lovely to see you here again.
Thank you, David. I did want to highlight what was said by Susanna Moorhead of the OECD about that as we come out of COVID, that it's going to be worse for poor countries, but also worse for women and girls. And this is something I think we should be thinking of. The gender aspects of the pandemic have been very hard. And if we are going to have women and girls suffering more in the future, we need to be thinking about it now and not just when it happens. Thank you.
So Marianne, just personally, I totally agree. This is a rather strange thing that men seem to be more likely to die, but that the impact on life, on particularly status and on opportunity is much, much greater for women and girls. And we just have to really, really take that into account. Marianne, if there's anything, if you want to come back and say what you would like to see us doing about that in general terms, that would be quite nice.
Well, I think, you know, it's something that we need to start talking about what is going to be done to help poor countries and particularly women and girls in the future through the mechanisms that have all gone moving backwards so fast. For example, the 2030 agenda, we're moving backwards when it comes to maternal mortality and so on and so forth. And I think we have to start campaigning well in advance. We tend to be very silent about what's happening in Africa in general, and what's happening in a lot of the developing countries. Everything is focused on the developed world. And I think there's got to be a change. And I'm not quite sure how it will come about and whether the GA meeting today will have done anything to help. Thank you.
Yeah, great. Thank you, Marianne. Do you know, it's really interesting when you're in the middle of something awful that's going on, you don't realize how awful it is. I remember that from Ebola in July, August 2014 in Monrovia. But I was talking to the economic advisor to the Prime Minister of Lesotho yesterday, and it was chilling what I heard, the magnitude of the misery and difficulty, children not in school for huge long periods, massive increase in food insecurity and malnutrition, big problems for women everywhere, and the awful challenges of hospitals and then colleagues dying. Doesn't sound good. I mean, it sounds, as I keep saying to myself, even worse than some of these scenarios that were created for the films like Contagion. It's really bad. So Marianne, I think you're right. We need to be talking about it now, not waiting for 6 months until all the nice analyses are done. Somebody's written to me. Is that you, Catherine? Did you just send me that text? Could you talk?
I did. Sorry. I just wanted to, hi, everybody. I just wanted to mention that one of the things that keeps coming up, especially in conversations with UNICEF and our friends, my friends there, is this incredible concern about girls' education. In a lot of countries where girls had just started to be educated as more of a standard, where they now have missed a year, it's very unlikely that they'll be provided with the opportunity to go back. And so in addition to the questions about domestic violence and about women taking on more and more home responsibilities over the long term, there's also a sort of generational impact of girls not being educated in the way that we anticipated this generation, and how to really compensate for that and make sure that 2 years from now, we're not just letting this continue to flow forward.
Yeah, very good. And Catherine, thank you for that. Now, 30 seconds from somebody, Scott Knox, 30 seconds. You've just come up with a great idea. I want everybody to know about it.
Okay, hi. Hello, everybody. Yeah, all I did was just hashtag pass the vax. I don't know if it'll work. Hashtags only ever work from a comms point of view if people think it says the right thing for them. So I looked up hashtag pass the vax just now on Twitter. It doesn't exist. I've just tweeted hashtag vaccine equity is vital for the world to recover from COVID-19. I pinched your phrase, David. Let politicians off the hook for their belief that we demand they vaccinate everyone in the country. The world's health workers and high-risk people should come first. Let your politicians know you. Hashtag pass the vax. Who knows? Give it a shot. I'll put it out through the media in Canada, right, and let's see if we can make it travel.
Thank you very much, Scott. Holly Wheeler, you haven't been on for a bit and you've just lit up your video. Let's hear from you.
Hello, lovely to see you. There were a few things, but the main thing that I wanted to say is that the women's thing is showing up everywhere, and it is much more extreme in the more countries with greater poverty. But what I'm noticing here is that women are taking up less training, they're taking up less leadership roles, they're doing more at home and less in the public realm and in the world. And I personally think that that's a big challenge for us longer term. So if you have any opportunities to support the women around you, to take up leadership and to be out there doing something, please support them, because I think that's really important. And Scott, I love the idea of pass the vax.
Thank you, Holly. I wanted to see Abdullah. I only know a few Abdullahs in the world. I'm not sure whether you're the Abdullah from Senegal that I know, but if you are, I'd love you to just let off your mute and just tell us where you're calling in from. We're moving to the end. I'd love it. Loy, I'm really only got about 15 seconds. Just tell us what you put in the chat, please. Loy, you've got an unmuting problem.
I've written an article on pandemic preparedness, response and recovery in the AIDMI, All India Disaster Mitigation Institute newsletter. It's about 3 pages. I've sent you a copy. Do have a look at it and comment on it. That's all.
You are a great man. That is Loy Rago telling about his work in India. John Atkinson, please, just toward closure.
The thing that sticks with me, David, is what we've been trying to play around is, so what's the wording that connects with people? And I still stay with, none of us is safe until we're all safe. So pass the vax links to that for me, and Scott already retweeted. Let's see what happens with it.
Thank you very much indeed. Wonderful, wonderful, wonderful. And as we close, just last word to Vicky Doyle. Only because we celebrate Nazim, we put his picture, or Peter's put his picture on today's thing. You and Nazim are a most amazing combination. Let us know what's happened. And everybody, Loy is saying read his article, so I will do that. But over to you, Vicky.
Okay, thanks, David. Just to say that Nazim has been in the recording studio. We're still waiting to do the final production of his latest song, which I think, as I alluded to the other week, it's all about trying to keep people going, because there is a lot of fatigue out there, and we've got to get people to look at those positive role models and to keep doing the things we should all be doing, but without telling people what to do. So it's a very feel-good song, but we're having a few production problems at the moment, but it will be out very, very soon, I promise you.
I thought you never had any problems in your operation. I thought it was just one.
You can't always account for Gambia and it's the national power grid and the main internet going down on multiple occasions lately.
Oh dear.
Even that one's outside our control.
Thank you very, very, very much indeed. Everybody, it's never enough time. I probably went on too long at the beginning. I just have to tell you one important reality, and that is that these meetings have turned into being an essential point of learning and sharing for our team, and for me in my role as Special Envoy on COVID for the WHO. What is happening now is that together with Catherine and John, Twee and others, I'm sort of developing the narrative in advance of the open online briefings, and then I am sharpening it afterwards. And so out of today's meeting, a lot of focus on the long COVID issue. Really important that we are needing to understand the equity implications, but also the implications for women of what is happening. And then we really need to be thoughtful about the epidemiology and not be deceived by any of the current narratives that seem to be floating around. It's not straightforward what is happening, and we need to study the Israel pattern with a great deal of care. We've got continuing challenges around the world. in India, in Africa, Latin America that need our attention. Thank you, Jane Badham, for being with us. Thank you, Miles Breeding, for being with us. And as Scott and others have been saying, we need to try to get the right messaging on the vaccine sharing to deal with the global problem. And Scott has kindly given us at least 2 hashtags that we can experiment with. We thank you very much indeed, Scott. Well, everybody, it is with great appreciation and affection that on behalf of our team, I say thank you. We'll be on this format again next week on Friday, 8 a.m. European time. Look forward to seeing those of you who can be there. And meanwhile, to AdSpikers, thank you. To Annie Appleyard, if you're still there, just because I haven't seen you for ages, it would be lovely to see you. Thank you for your question about rapid tests. I will get you the answer when I can. So thank you, everybody. Bye-bye. Have a good weekend, and let's stick together.